After years of treating patients with Sjogren's, a pattern started to emerge that I wasn't expecting. The patients who declined the fastest weren't the ones with the driest mouth or the driest eyes. Dryness is uncomfortable, but it's rarely what puts someone in the hospital. The patients who declined the fastest were the ones whose Sjogren's had quietly moved past the glands and into their organs, and by the time anyone noticed, it had already been doing damage for years. I see Sjogren's in clinic every week, and I've also seen it in the hospital, in forms that most patients, and honestly, most doctors, don't expect. Today I want to walk you through the severe and end-stage signs of Sjogren's, going organ by organ, so you know exactly what not to miss. I want to say up front, Sjogren's is manageable, and most people with it live full, normal lives. But there is a subset of patients where the disease moves beyond dry eyes and dry mouth into systemic, organ-threatening territory. Those are the signs I want to cover today. Before we go organ by organ, I want to explain why this happens at all, because it changes how you think about every symptom that follows. Sjogren's isn't just dryness. Underneath the dryness is a slow, steady infiltration of white blood cells, mainly lymphocytes, into glandular tissue. In most patients, that infiltration stays contained to the salivary and lacrimal glands, which is why dry mouth and dry eyes are the hallmark. But in roughly a third of patients, that same immune process doesn't stay contained. It spreads to other organs, and depending on where it lands, the consequences can range from mildly annoying to genuinely life-threatening. That's the group I want to help you recognize today, because early recognition is the single biggest factor in preventing permanent damage. I also want to name something that I think gets lost in most conversations about Sjogren's. This disease is frequently underdiagnosed for years before someone finally gets a name for what's happening to them. Part of that is because the symptoms of severe, systemic Sjogren's often show up in a specialist's office that has nothing to do with rheumatology. A nephrologist sees the low potassium. A pulmonologist sees the scarring on a CT scan. A neurologist sees the numbness. A dentist sees the rapid decay. Each specialist is looking at their own piece of the puzzle, and unless someone connects the dots back to the dryness the patient may have mentioned in passing, or ordered the right antibody panel, the underlying Sjogren's can go unnamed for years while the systemic damage quietly continues. That's exactly why I'm walking through this organ by organ today, so that if you're living with unexplained symptoms in any of these areas, you have a framework to bring back to your own doctor. 1. The kidneys. Sjogren's can attack the kidneys in a way that's easy to miss because it often doesn't hurt. The classic finding is something called distal renal tubular acidosis, or type 1 RTA. The kidneys lose their ability to properly regulate acid in the blood. This happens because the same lymphocytic infiltration that damages salivary glands can also damage a specific type of cell in the kidney called the intercalated cell, which is responsible for pumping acid out of the body. When that pump fails, acid builds up in the blood and potassium quietly drops. This can happen so gradually that patients don't notice anything is wrong until it's severe. In the medical literature, this has shown up as sudden muscle weakness, and in the most dramatic reported cases, complete paralysis of all four limbs, dangerous heart rhythms, and even rhabdomyolysis, where muscle tissue itself starts to break down. In more than one published case, a patient's very first sign of having Sjogren's at all was showing up in an emergency room unable to move their arms and legs, with a potassium level low enough to be life-threatening. Beyond RTA, Sjogren's can also cause tubulointerstitial nephritis, which is inflammation deep within the kidney tissue itself, and less commonly glomerulonephritis, especially in patients who also have cryoglobulinemia. Your doctor can pick these up through blood work, urine studies, and in some cases, a kidney biopsy to see exactly what type of involvement is present. The warning signs to watch for: unexplained muscle weakness, especially if it comes on gradually or worsens with heat or exertion, kidney stones that keep recurring, an abnormally low potassium or bicarbonate level on routine labs, or unexplained swelling in the legs. If you have Sjogren's and any of these show up, that's worth flagging to your rheumatologist and nephrologist right away, not waiting for your next scheduled visit. If this one hit close to home, type strength in the comments. I want whoever needed to hear this today to know, you are seen, and you are stronger than this disease is trying to convince you that you are. 2. The nervous system. Dry mouth and dry eyes are the well-known signs of Sjogren's, but the nervous system involvement is where I've seen some of the most severe presentations, and it's also one of the most underappreciated complications of this disease. Peripheral neuropathy is the most common form. Burning, numbness, or tingling in the hands and feet. But in more severe cases, Sjogren's can cause small fiber neuropathy, where the smallest, most delicate nerve fibers in the skin are affected. This can be intensely painful, and it's often missed entirely because standard nerve conduction studies, which measure larger nerve fibers, can come back completely normal. If you've been told your nerve tests are normal but you're still in daily pain, small fiber neuropathy is something to specifically ask about, because it usually requires a specialized skin biopsy to diagnose. There's also a rarer but more serious pattern called sensory ataxic neuropathy, where the nerves responsible for position sense are affected. This can cause patients to lose their balance, especially in the dark or with their eyes closed, because they can no longer feel where their feet are in space. In rarer cases still, Sjogren's can involve the central nervous system directly. This can look like optic neuritis, where the nerve behind the eye becomes inflamed and vision suddenly changes, or it can look like transverse myelitis, where inflammation of the spinal cord itself causes rapid weakness or numbness in the legs. Some patients with this pattern are initially misdiagnosed with multiple sclerosis or neuromyelitis optica spectrum disorder before Sjogren's antibodies are ever checked. This is one of the true medical emergencies on this list, because the window to treat spinal cord inflammation before permanent damage sets in can be narrow. Finally, Sjogren's can affect the autonomic nervous system, the part of your body that runs in the background, controlling heart rate, blood pressure, digestion, and temperature regulation without you thinking about it. When this is affected, patients can develop symptoms like feeling dizzy or lightheaded every time they stand up, an unusually fast heart rate with minimal exertion, or digestive symptoms that don't have another clear explanation. This is often missed because it doesn't look like a nerve problem on the surface, and it's frequently written off as anxiety or deconditioning before anyone connects it back to Sjogren's. The warning signs to watch for: new numbness or tingling that's spreading or getting worse, sudden weakness in the legs, sudden vision changes, unexplained problems with balance, or arresting heart rate and blood pressure that swing wildly without explanation. If you notice any of these, especially the sudden ones, don't wait to get that worked up. If this is familiar, type resilient in the comments. I want whoever's living with nerve pain today to know, this is real, it is not in your head, and you are seen. 3. The lungs. Two things I watch for closely in the lungs, because they can progress silently for years before someone feels truly short of breath. First, interstitial lung disease, where chronic inflammation slowly scars the lung tissue. There are a few different patterns this can take. Nonspecific interstitial pneumonia is the most common pattern seen in Sjogren's, though usual interstitial pneumonia and organizing pneumonia can also occur. Early on, interstitial lung disease can look like nothing more than a dry cough. Over time, it can progress to shortness of breath, especially with exertion, and it can show up clearly on a high-resolution CT scan long before someone feels short of breath at rest. This matters because scarring, once it's set in, generally can't be reversed. The goal is to catch and treat the inflammation before it gets to that stage. Second, small airway disease and bronchiectasis. This happens because the same dryness that affects the mouth and eyes also affects the lining of the airways, thickening the normal protective secretions and making it harder to clear mucus and bacteria. Over time, this can cause the airways to become permanently widened and scarred, which makes patients more prone to recurrent lung infections, sometimes several times a year. Less commonly, Sjogren's can cause pulmonary hypertension, where the blood pressure inside the lungs' blood vessels rises, making the heart work harder to pump blood through the lungs. This can eventually strain the right side of the heart itself. The warning signs to watch for: a new, persistent dry cough that doesn't have another obvious cause, getting short of breath doing things that never used to bother you, recurrent lung infections or pneumonia, or swelling in the ankles that could suggest the heart is being strained. If any of this sounds familiar, get pulmonary function tests and imaging sooner rather than later. This is one of the complications where early treatment makes the biggest long-term difference. Type breathe in the comments if this one hit home. If breathing itself has become something you have to think about, I want you to know, you are not overreacting, and you are seen. 4. The blood and lymphatic system. This is the one I want you to pay closest attention to, because it's the complication of Sjogren's that concerns rheumatologists the most: lymphoma. Patients with Sjogren's carry a meaningfully higher lifetime risk of developing non-Hodgkin lymphoma compared with the general population, and this risk is one of the reasons Sjogren's is taken so seriously even though the day-to-day symptoms can seem mild. The most common subtype is malt lymphoma, which stands for mucosa-associated lymphoid tissue lymphoma, and it often develops right in the salivary glands themselves, where the chronic inflammation has been simmering for years. The warning signs for this are specific, and I want you to remember them. A persistently swollen salivary or parotid gland that doesn't go away or that keeps getting bigger, new, or enlarging lymph nodes anywhere in the body, unexplained weight loss, drenching night sweats that soak through clothing or sheets, or blood counts that suddenly and unexpectedly drop. Persistent parotid gland swelling in a Sjogren's patient should never be waved off as just Sjogren's without specifically ruling this out, because early lymphoma is far more treatable than lymphoma that's been growing quietly for years. Beyond lymphoma, Sjogren's on its own, without any malignancy involved at all, can also lower blood counts. This can affect white blood cells, red blood cells, or platelets, sometimes all three at once. This shows up on a routine complete blood count, or CBC, and it needs to be tracked over time rather than checked once and forgotten, because these numbers can shift as disease activity changes. The warning signs to watch for: any lasting gland swelling, unexplained lumps, night sweats, weight loss you didn't intend, or blood counts trending in the wrong direction on routine labs. If you notice these, this is not something to wait out. If this section made you pause, type hope in the comments. I want you to know that catching things early is exactly why you're watching this, and that matters. You are seen. 5. The skin and blood vessels. Sjogren's can cause a form of vasculitis, which is inflammation of the small blood vessels. This most often shows up as small, reddish-purple spots on the lower legs called palpable purpura, which are raised, don't fade when you press on them, and can sometimes ulcerate if severe. This can be a marker of more significant systemic inflammation, and in some patients it's tied to something called cryoglobulinemia, where abnormal proteins in the blood clump together, especially in colder temperatures, and can affect the skin, the nerves, and the kidneys all at the same time. When cryoglobulinemia is present alongside vasculitis, it's generally treated more aggressively, because the same process that's causing the skin findings can also be quietly damaging other organs. Many patients with Sjogren's also experience Raynaud's phenomenon, where the fingers or toes turn white, then blue, then red in response to cold or stress, due to the blood vessels in the extremities spasming shut temporarily. This is common and usually not dangerous on its own, but in severe, long-standing cases it can occasionally lead to skin breakdown at the fingertips if blood flow is restricted for long enough. The warning signs to watch for: new, unexplained purple or red spots on your legs that don't fade with pressure, fingers or toes that change color dramatically with cold exposure, or any skin ulcers that aren't healing. If you notice new purpura, that's worth an urgent evaluation, not a wait-and-see approach. Type healing in the comments if you're dealing with this. I want you to know your skin telling a story doesn't make it any less real. You are seen. 6. The eyes. Everyone knows Sjogren's causes dry eyes, but the medical term for it, keratoconjunctivitis sicca, describes a spectrum, and severe cases sit at the far end of that spectrum in a way most people don't expect. Left unmanaged, severe dryness can progress to actual damage of the eye's surface. This can include filamentary keratitis, where strands of damaged cells stick to the surface of the eye and cause a foreign body sensation with every blink, corneal abrasions, and in the most severe cases, corneal ulcers or even corneal perforation, which can permanently affect vision. This isn't common, but it happens most often in patients who've gone a long time without adequate treatment or follow-up, because the eye's surface simply can't protect itself the way it's supposed to without enough tear film. This is why regular ophthalmology follow-up matters even when dry eye feels like just an annoyance. Untreated severe dryness isn't only uncomfortable in the moment. Over years, it can cause damage that doesn't reverse, and by the time vision changes are noticeable, some of that damage may already be permanent. The warning signs to watch for: eyes that feel gritty or painful most of the day despite using drops regularly, a sensation like something is constantly in your eye, sudden changes in vision, or increasing light sensitivity. If any of these apply to you, that's worth an eye exam, specifically looking at the surface of the cornea, not just a vision check. If your eyes have been through it, type clarity in the comments. I want you to know that protecting your vision now is not vanity, it's care. You are seen. 7. The dental and oral health. Chronic dry mouth doesn't just cause discomfort, it changes the entire chemistry of the mouth. Saliva does far more than most people realize. It neutralizes acid, washes away food particles and bacteria, and delivers minerals that help repair the enamel on your teeth every single day. Without enough of it, patients with Sjogren's can develop rapid, severe tooth decay, sometimes losing multiple teeth in a surprisingly short period of time, even in people who brush and floss diligently and have never had dental problems before. Oral yeast infections, called oral candidiasis, are also common in severe dry mouth, and can cause burning, redness, and cracking at the corners of the mouth, along with a persistent altered taste. Beyond the mouth itself, severe dryness can also affect the throat and esophagus, making it harder to swallow dry foods without extra liquid, and in some patients contributing to chronic irritation further down the digestive tract. If you have Sjogren's, regular dental visits aren't optional maintenance, they're part of managing the disease itself, and your dentist should know you have Sjogren's so they can watch specifically for this pattern of rapid decay rather than treating each cavity as an isolated event. The warning signs to watch for: new cavities appearing faster than they used to, teeth that feel like they're breaking down despite good hygiene, persistent burning in the mouth, or difficulty swallowing dry foods without water. If this sounds like you, loop your dentist in on the Sjogren's diagnosis specifically. Type smile in the comments if this one is close to home. I want you to know that something as small as your smile is worth fighting for. You are seen. 8. The joints and muscles. Joint pain is extremely common in Sjogren's, and most of the time it shows up as arthralgia, pain without much visible swelling, affecting the small joints of the hands, wrists, and knees. This alone isn't usually a sign of severe disease. But in a smaller subset of patients, Sjogren's can cause a true inflammatory arthritis with visible joint swelling, and in overlap cases where Sjogren's occurs alongside rheumatoid arthritis or lupus, that joint involvement can be more aggressive and, if untreated, contribute to joint damage over time. Sjogren's can also overlap with inflammatory myopathy, where the muscles themselves become inflamed. This shows up as genuine muscle weakness, not just fatigue, difficulty raising your arms above your head, trouble standing up from a low chair, or trouble climbing stairs that isn't explained by joint pain alone. This is picked up through blood tests looking at muscle enzymes, and sometimes an MRI or muscle biopsy to confirm the diagnosis. The warning signs to watch for: joint swelling you can see or feel, not just pain, or genuine muscle weakness where a task that used to be easy, lifting something overhead, standing from a chair, has become physically difficult, not just tiring. If you notice real weakness rather than just fatigue, that distinction matters, and it's worth mentioning specifically to your rheumatologist. If this is your experience, type grounded in the comments. I want you to know that pain no one else can see is still real pain, and you are seen. 9. The digestive system and liver. The same dryness that affects the mouth can extend down into the esophagus, making it harder to swallow, especially dry or dense foods, and in some patients contributing to acid reflux because saliva normally helps neutralize stomach acid that creeps back up. Beyond the esophagus, Sjogren's has also been associated with reduced motility further down the digestive tract, which can look like bloating, early fullness, or symptoms that resemble gastroparesis, where the stomach empties more slowly than it should. There's also a recognized overlap between Sjogren's and liver involvement, most notably primary biliary cholangitis, an autoimmune condition that slowly damages the small bile ducts inside the liver. This can be present for years without symptoms, showing up only as a mildly abnormal liver enzyme on routine blood work, which is exactly why it's easy to miss. Less commonly, Sjogren's has also been linked to autoimmune pancreatitis, causing abdominal pain and digestive symptoms tied to inflammation of the pancreas itself. The warning signs to watch for: difficulty swallowing that's gotten worse over time, persistent bloating or early fullness after small meals, unexplained itching of the skin, which can be an early sign of bile duct involvement, or liver enzymes on routine labs that are creeping upward without another clear explanation. If you notice these, ask specifically for liver function tests as part of your regular Sjogren's monitoring, not just when something feels wrong. Type nourished in the comments if this section speaks to you. I want you to know that struggling with something as basic as eating comfortably is exhausting, and you are seen. 10. The heart, and a special note for pregnancy. Sjogren's can affect the heart in a few specific ways. Chronic inflammation has been associated with QT prolongation, a change in the heart's electrical rhythm that can, in rare cases, predispose to dangerous arrhythmias. Less commonly, Sjogren's can cause pericarditis, inflammation of the lining around the heart, which typically causes sharp chest pain that changes with position or breathing. There's one cardiac complication of Sjogren's that I want every woman of childbearing age with this diagnosis to know about specifically, because it doesn't affect the patient directly, it affects her baby. Many patients with Sjogren's carry antibodies called anti-Ro SSA and anti-La SSB. During pregnancy, these antibodies can cross the placenta and, in a small percentage of pregnancies, attack the electrical conduction system of the developing fetal heart, causing what's called congenital heart block. This can range from a mild, first-degree delay in the heart's electrical signal to a complete block that requires a pacemaker at birth or shortly after. This is uncommon, but it's serious enough that any woman with Sjogren's who is pregnant or planning to become pregnant should have her anti-Ro and anti-La antibody status known well in advance, so that specific fetal heart rate monitoring can be built into her prenatal care starting in the second trimester. The warning signs to watch for: chest pain that changes with breathing or lying down, a racing or irregular heartbeat, or, for pregnant patients specifically, any reduction in fetal movement or an abnormal heart rate detected on routine prenatal visits. If you are Sjogren's positive and planning a pregnancy, this is a conversation to have with both your rheumatologist and your obstetrician before you conceive, not after. If this section matters to you or someone you love, type "protected" in the comments. I want every parent and parent to be watching this to know, being vigilant is an act of love, and you are seen. So overall, we've covered the kidneys, the nervous system, the lungs, the blood and lymphatic system, the skin and blood vessels, the eyes, the mouth, the joints and muscles, the digestive system and liver, and the heart. Sjogren's is very treatable, and most of these severe outcomes are things we can prevent when they are caught early. But they're easy to miss if you and your doctor aren't specifically looking for them, because on the surface, this disease is so easily mistaken for just dryness. Now here's the pattern I want to come back to, because it's the part that surprised me the most. When I looked back at the patients who declined the fastest, it was almost never the ones who complained the loudest about dry eyes and dry mouth. It was the quiet ones, the ones who assumed their fatigue was just stress, who assumed their nerve tingling was just getting older, who assumed a swollen gland would go away on its own, who assumed their breathlessness was just being out of shape. Recognizing these signs early, in yourself or in someone you love, is the difference between managing this disease and being managed by it. If any of this sounds familiar, don't wait. Bring it up with your rheumatologist directly, and ask specifically about the organ systems we covered today. You don't have to bring up all 10 at once. Start with the one that scared you the most while watching this, and go from there.